Welcome to Podium Perspectives, powered by Vaniam Group.
Welcome to Podium Perspectives, Advances in the Treatment of Gastrointestinal Cancers, ASCO GI Highlights, a new podcast that shares up-to-date insights across oncology and rare diseases. I'm Dr. Rachna Shroff from the University of Arizona Cancer Center, and I'm excited to participate in this series with my colleague, Dr. Aparna Parikh from Mass General Brigham Cancer Institute.
Thank you so much for the introduction, Dr. Shroff. I'm really excited to have this discussion with you today. In today's episode, Vaniam Group has brought us together to discuss the updates from ASCO GI 2026 on GI cancers.
Great, let's dive in. And we're going to start with the upper GI space because I would say that that was really where some of the most exciting developments and the most numerous developments came out of ASCO GI 26.
Yeah, absolutely. I think really exciting times for upper GI. I think we've seen such tremendous project progress in this space over the last couple of years, and I think new biomarkers that are really coming to light over the last few years. So we've had HER2. HER2 has been there for a long time. For decades and decades, our workhorse has been Herceptin. And then over the last couple of years, we saw the advent of checkpoint inhibitors into the HER2 gastric space with Herceptin, Pembro, and chemotherapy coming to the first line setting. We'll talk about the other biomarkers, I think, in a minute here, but really one of the pivotal abstracts that we saw in a big headliner was the Horizon GEA-01 study. And this study looked at the first line setting for HER2 metastatic gastroesophageal cancer, adenocarcinoma specifically, and was looking at the combination of zanidatamab plus chemotherapy with or without tislelizumab, which is a PD-1 inhibitor, versus what historically has been the standard of care, trastuzumab and chemotherapy in the first line setting. So this was a really exciting data. It was a phase 3 trial, and what we saw was a significant PFS improvement with the zanidatamab-based regimen versus trastuzumab and chemotherapy. It is the first phase 3 study that has showed superiority over trastuzumab in the frontline setting with a median PFS exceeding 12 months. And though it did not necessarily compare to our standard of care, which is now HER2 Pembro chemotherapy, not only with the PFS data, but the OS data, I think was really, really exciting. And, we're seeing nearly 24 months for this patient population, which is remarkable. And so a lot of excitement to see what's going to happen in this space over the next year with what the FDA does with approval. But I think many of us are thinking that this will be the new standard of care for gastric cancer patients. Curious your thoughts on this data, Dr. Shroff.
Yeah, I have to say, I would say this was probably one of the biggest splashes that came out of ASCO GI, and I think is proof of principle that zanidatamab is a really good HER2 targeting agent. And I mean, it's a bispecific, but it's interesting because it just targets two different spots in HER2, and so as a result, it's really that pathway that it's regulating, and we use it in biliary cancers. It's already FDA there, and so those of us who treat biliary cancers are really comfortable with it. But I would agree. I mean, I would say that the median OS of the tislelizumab and zanidatamab arm with the chemotherapy with 26.4 months is probably the thing that was the most exciting. And I think there's a lot of questions of, yes, it's not compared to the current standard of care, but at the same time, I think what this study answers is we have a new HER2 targeting agent that we probably should be using in the frontline setting with zanidatamab over trastuzumab. And, I think also importantly, PD-L1 status did not seem to matter, at least in the exploratory analyses. And this was just the first interim analysis. So I think as we get more and more data and more updates with longer median follow-up, I think it'll be really important.
And I'm curious from your perspective, I mean, you treated a lot of patients now because you're a biliary doc as well. The toxicity has definitely come up as a issue, and I think for our community oncologists as they sort of think about how they incorporate Zani potentially into gastric cancer patients over the next year. Any lessons learned from kind of managing that GI and the nausea and
Yeah, I mean, I
kind of
think
guidance?
I think that's a really good point because as the way the protocol was written for Horizon, uh, preemptive or prophylactic anti-diarrhea medications were included, and even still, there was a relatively higher rate of diarrhea as the probably one of the most important AEs. And I just think that that's exactly right. Is preemptive and prophylactic and aggressive diarrhea management is really important with zanidatamab. Impressively, the infusion reactions, which was another concern that everybody really had with this drug, were relatively early on, short-lived, and easily managed with kind of our typical approaches to infusion reactions, and then by and large kind of go away. So I think it's the diarrhea that really jumps out at everybody, and I think we know that as a in general class effect for HER2 targeting agents, but I think in this one really will require aggressive preemptive and prophylactic diarrhea management.
Oh, that's, I think, super helpful advice.
So, the other kind of area that you mentioned, targeted therapies in gastric cancers and upper GI malignancies, and the other area that's been a really hot area for discussion has been Claudin 18.2 positive upper GI malignancies. And Claudin 18.2 has really emerged as an interesting target across a lot of different spaces, but I would say that the upper GI world is probably the furthest along in terms of its drug development for patients, in the sense that the anti-Claudin 18.2 antibody zolbetuximab plus chemotherapy has really become one of our standard approaches in Claudin 18.2 positive HER2 negative advanced upper GI cancers. And so that knowing that zolbetuximab has been part of our kind of upfront approach to Claudin 18.2 positive patients, there have been a number of other follow-on studies, including the Illustro study, which was an updated cohort data was presented at ASCO GI this year. And in this cohort, again, it was HER2 negative upper GI advanced 18.2 expressing patients. And I will say, and I would love your thoughts on this, is there's always been kind of a little debate, and it varies across the different cancer types in terms of what constitutes Claudin 18.2 expression and what is moderate or intermediate expressing versus high. And in this study, the IHC stating in those who were 50 to 75% of tumor cells was classified as intermediate, and then greater than or equal to 75% was high. And this study looked at zolbetuximab in combination with FOLFOX, the standard chemotherapy, with nivolumab, the immunotherapy. And the endpoints that were looked at were typical efficacy endpoints. And what they found is that the median PFS in this group was 14.8 months in all comers, but slightly higher, 18 months in patients with high Claudin 18.2 expression. And similarly, there was an overall response rate of 62.9% in all comers, but closer to 70%, 69% or so in patients with high Claudin 18.2 expression. The general consensus here is that this combination of zolbetuximab with immunotherapy with chemotherapy definitely shows efficacy, but particularly in that subset of patients who are greater than 75% positive tumor cells. So, I would love to know what your thoughts are. I mean, there's still ongoing studies right now looking at zolbetuximab in other combinations and with pembrolizumab, for instance. But, how do you think that this kind of advances or moves the needle, helps clarify the Claudin 18.2 study?
Yeah, I think I think a couple of really important points that you made. I think I think one of the key points with the study, which at least though you mentioned that the benefit was really driven by the patients that were in the higher group, their upcoming phase 3 strategy is looking at an all-comer patient population. And so, can you potentially obviate the need of that biomarker selection depending on how that reads out? And we know that many places are still kind of struggling to get Claudin 18.2 just tested routinely in all of their patients. And so, though in clinical practice, we're testing Claudin 18.2, we're testing HER2, we're testing PD-L1, we're testing MSI high. I think those are the key biomarkers for gastric cancer. Is there a path forward where in the phase 3 that this expands the patient population really for even the low patients for 18.2? So obviously not the non-expressors, but the low expressors too, even though the impact was really driven by, I think, the higher Claudin. But I think not what they're shooting for in the registration study that we'll see subsequently. Um, so I think we'll see. I think really important study. I think there is that overlap of patients who are eligible for immunotherapy and Claudin 18.2 high, and so I think this is a data set that people have been looking to. What do I do with those patients that are both candidates for checkpoint inhibitor in the first line, but also have that 18.2 to try to meet that Venn diagram overlap as well. So look forward to their phase 3 data, but I think we'll see more of Claudin 18.2, not just in gastric cancer, like you said. I think being developed in other GI cancers like pancreatic cancer as well.
Yeah. And I will say, from what I've heard from a lot of people, again, kind of speaking to toxicity, the Zolby nausea
Hmm.
is an issue, and
Yeah.
I think people are getting better at understanding how to manage it and again, prophylax for it. But I think that will be, if it is going to be an all-comer patient population, and these are upper GI patients who have gastric dysmotility and have other issues that already contribute to nausea, I think it's going to be an important, you know, learning curve for that.
Yeah, and I was talking to some Asian colleagues, and they were saying that, for in some of the early days, they were actually admitting patients, for nausea management, which is not really tenable in the outpatient setting. So I think really aggressive, antiemetics is going to be important. There was one other, abstract that was, interesting. Going back to the HER2 space, we have the burgeoning of ADCs, I think, across the board, but at least for GI cancers, the ADC that has come forward the most has been trastuzumab deruxtecan, approved in gastric cancer, post Herceptin use, approved in colorectal cancer. We use that often kind of post the Mountaineer regimen with Herceptin and tucatinib. But there was another abstract looking at a bispecific. So a bispecific antibody called volrustomig. I'm not exactly sure how to pronounce it, but from AstraZeneca, and combined it with chemotherapy and trastuzumab deruxtecan, but really trying to extend ADCs in a broader population. Unlike breast cancer, where we've seen activity in the ultra lows and low HER2 patients, we haven't had as much activity in the GI space. So I think people, or for the low patients in particular. So I think this was a interesting data set trying to really see if there's an opportunity to not only improve the efficacy of the intermediate and high, but expand the patient pool to the HER2 low patient population as well. I'm curious if you had any thoughts on that strategy.
No, I mean, I think this is absolutely a study to have our eyes on, right? Because it could be a game changer the way that, trastuzumab deruxtecan in the HER2 low breast population has been, right? And I think it would be really helpful for us to be able to offer this to a wide range of HER2 positivity, if you will. So, well, why don't we shift gears, because the other space that I think really had some exciting developments was in the colorectal space. And, I think one of the big waves has been breakwater. And at each of our meetings, we've gotten really great updates on this data set as it relates to BRAF targeting in colorectal cancer. And GI ASCO was no less. In this analysis, we basically got the update on looking at the dual targeting of encorafenib with cetuximab in BRAF V600E mutated metastatic colorectal cancer with a backbone of FOLFIRI. So we had previously seen FOLFOX with this combination that had demonstrated significant efficacy. And now we got the update that looked at 147 patients that were randomized to control versus EC plus FOLFIRI. And in this data, once again, not surprisingly, and again, just proof of principle that this really needs to be our approach for BRAF positive patients, there was a significant improvement in confirmed ORR. And the overall response rate was quick. It was durable. Overall survival data still immature, but looking really, really positive as well. And so, I think in general, we have now seen kind of consistency, which I think is really wonderful. That the encorafenib cetuximab backbone, I mean, regimen, the chemotherapy backbone, if you will, does not matter, does not seem to matter, at least in these patients that are BRAF V600E positive. I would love to hear your thoughts as a colorectal expert in terms of what this adds to the data set, if you will.
Yeah, I mean, I was so excited to have this data. I think we've all been waiting for it because many of our patients who have BRAF positive disease, again, this is V600E disease specifically, may have been treated actually in the adjuvant setting with FOLFOX already. And after, as you all know, after getting lots of FOLFOX, even 3 months of CAPOX, 6 months of FOLFOX, especially, patients' neuropathy can be really limiting. And when you saw the numbers from Breakwater with the FOLFOX cohort, 30 months versus 15 months with standard chemotherapy, doubling, truly, truly remarkable. Um, we all needed to see that it was okay to give FOLFIRI because there are patients that are just not FOLFOX eligible. And so this gives me a lot of confidence now for my patients who I can't give FOLFOX to in the first line. I can feel really good about kind of preserving their digits and kind of preserving their functional status, but still maintaining those survival outcomes that we want for our patients with V600 disease. Again, OS is still maturing, but looks really promising. So, as of ASCO GI, I don't have hesitancy anymore in using FOLFIRI as a backbone, particularly for the FOLFOX ineligible patients. Yeah, so another really exciting data set that we saw from ASCO GI was an update from the MSI high space. So, MSI high, the landscape of first line space has drastically changed over the last several years. So, for several years, we had PD-1 monotherapy as our standard based on the Keynote 177 data, looking at pembrolizumab in the first line versus chemotherapy. And that really changed the landscape for checkpoint inhibitors in the MSI high patient population in colorectal cancer specifically, after the tumor agnostic indication came to be. And then over the last year, we saw tremendous updates from the Checkmate 8HW study. And this was a study looking at dual checkpoint inhibitors versus mono versus chemotherapy. So with the ipi-nivo combination. And we saw remarkable results with that. And now, curing patients with dual checkpoint inhibitors at, 3 and 4 years, no evidence of disease progression. Again, better than just monotherapy alone. And so Commit now adds to that data set, and was looking at the combination of FOLFOX with atezolizumab versus just chemotherapy alone in the first line setting for MSI high patients. It was a phase 3 study. And again, this was designed well before we had checkpoint inhibitor only strategies. So at the time that Commit was designed, we still didn't really know if we could get rid of chemotherapy. Though it was a positive study when you looked at the combination, it's really hard to know how to make sense of this in light of ipi-nivo. And, though I think an important data set that contributes to the literature that, checkpoint inhibitors, and in this study really did need the chemotherapy. The atezolizumab alone arm did quite poorly. But, do we actually need the chemotherapy period in light of ipi-nivo, I think is still an important question. Rachna, I'm not sure your thoughts on that.
Yeah, no, I mean, I think it's like you said, like this was such an important study, and unfortunately, just because of the time it took to get going and accrue and all of that, some of the amendments and things really had to affect the ability for this study to be completed. But I mean, I think it's exactly like you said. I think what we now know is that we absolutely can and should offer immunotherapy to our mismatch repair deficient MSI high metastatic colorectal cancer. And I think what's very, I guess, reassuring or helpful is knowing that There's really no additional safety signals that come from giving a chemotherapy arm with the addition of the atezolizumab. And I would say kudos to the team for being able to just pivot and make the necessary amendments to be able to at least continue to ask some important questions.
I know there was lots of excitement this year, but I hope we found this helpful, and we really appreciate you listening to this episode of Podium Perspectives.
Please do follow and share to stay current as new data comes out. This episode is for educational purposes only and is not medical advice. We look forward to seeing you next time. Thank you so much for doing this with me, Dr. Parikh.
Thanks for joining Podium Perspectives, powered by Vaniam Group. This episode is for educational purposes only and is not medical advice.